morning. Thank you for joining our October webinar on breast cancer awareness. If you're not familiar with my voice, I am Ashanti Jefferson, the manager of the Wellness Department, and we are very lucky to have one of our medical directors, Dr. Jennifer Carter, on to discuss breast cancer awareness for us.
I wanted to share a story of a breast cancer warrior, a survivor who doesn't mind me allowing you a peek behind the curtain if it makes a difference in the lives of someone else. She cried off and on, alone in the car for nearly 200 miles. It was January 2004, and she was returning from a stay with her parents. She had spent weeks covering mirrors and guarding the phone and watching through the night to ensure her mother's peace and safety. Her mother no longer recognized her family or her own reflection. She saw threats where none existed and eloped from the home when the opportunity presented itself. Her mother had been diagnosed with dementia, Alzheimer's, and her dad was trying to care for her at home alone when his daughters were not available. She was home and just looking forward to a good night's sleep after so many restless nights. She crawled into bed and rolled onto her right side and felt some tenderness, then a lump in her right breast. She wondered what's going on there. She made an appointment with her OBGYN. He saw her and reassured her. She was young, not even 45 years old, nothing to worry about. She was scheduled for a routine screening mammogram and provided instruction on how to examine her breast. She sat there thinking, well, the self-exam that I did was what brought me into the office. I found the lump. The mammogram was performed on February 2nd, 2004, and it was followed by a recommendation for additional ultrasound testing. And after the ultrasound, a biopsy. This was not headed in the direction she had expected. But again, she was reassured, you're young, no worries, no worries. Days after the biopsy, she sat waiting in the surgeon's office. She turned to her husband and said something's wrong. He shook his head and said, it's all good, it's all good. But she knew. The surgeon came in and began sharing the pathology report. Lobular carcinoma in situ, invasive ductal carcinoma. She had cancer. No, I had cancer. After I heard the diagnosis, my mind seemed to retreat to some hiding place. The doctor's lips were moving, but I heard nothing he said. I was shouting in my head like, hey, you need to hear what he's saying. Can't you see what's happening here? Can't he see? Why doesn't he just stop? Just stop talking. Slowly, I was able to recover enough to nod in agreement to what I wasn't really sure. I was 44 years old. I had a 6-year-old and a 3-year-old. What about them, God? What's going to happen to my babies? Yes, he was saying mastectomy. No, he said possible bilateral mastectomies. This was a walking nightmare. Everything in me wanted to hit rewind. I wanted to go back to yesterday. Even if it had not been great, it was better than this. But that was not an option. I was in a fight, and the punches just kept coming. Surgery, chemotherapy, baldness, fatigue, and to add insult to injury, weight gain. Yes, everything had changed, and it would never be the same. Never. And I would never be the same either. Breast cancer, what is it? Basically, cells generally grow and divide and die at a regular rate. And new cells replace old or damaged cells. But when abnormal cells divide and grow out of control, they form lumps or tumors. or they spread and they destroy normal body tissue. That's cancer. Cancer can start almost anywhere in the body, but if it starts in the breast, it's breast cancer. Here, I said earlier that sometimes when cells divide and grow abnormally, they can create lumps and tumors. Sometimes those tumors are benign, meaning they're not cancer, and other times they're malignant, meaning they are cancer. In breast cancer, you might also hear the terminology early versus advanced, just so that you know, early means it's less than an inch in size. Doesn't mean it just started, because these cancers can grow for many, many years before they're detected. Early just means it's small, less than an inch, and advanced means it's already spread beyond the breast. I guess the question is, how common is this? Breast cancer is actually fairly common. Behind skin cancer, it's the most common cancer in women in the US. I really like this next bullet, the 1 in 8. It kind of puts it in perspective. Every one of us probably has at least 7 friends. So if you're in a group of 8, probably at least one woman is likely over the course of her lifetime to become impacted with breast cancer. The American Cancer Society estimated for this year in the US about 297, almost 300,000 new cases of invasive breast cancer being diagnosed in women. About 55 to 56,000 ductal carcinoma in situ, which is an early cancer, which has not yet invaded beyond the cells. The duct cells will be diagnosed. We'll talk about the different types in a second. About 43,000 to 44,000 women will die from breast cancer. Men, of course, do have breasts and can get breast cancer, but they're a small percentage of the numbers, about a half to 1%. I think what I like about this slide is the last bullet, and there are more than 4 million breast cancer survivors in the US. So just because you have a diagnosis doesn't mean you die. Well, we just talked a little bit about survivors. And this slide just tells us about the percentage of people with the same type and stage of cancer that are still alive in this slide 5 years after their diagnosis. Women who present with localized disease, meaning the cancer hasn't moved outside of the breast, about 99% of them are still alive at 5 years. Yeah, that's incredible. As far as regional spread, if been nearby structures that have been encroached upon by the tumor, 86% of those are still alive at 5 years. When you start to get distant spread, the survival rates are poor, 30%. That last is just an average. I think the most important thing I take away from this slide is the importance of early diagnosis, early treatment, because the outcomes are so much better. Who gets breast cancer? Women, of course, but which women? White women are slightly more likely to develop breast cancer, except for ages under 40. For ages under 40, Black women are much more likely to develop cancer, breast cancer, and to develop a more aggressive, more advanced stage of breast cancer. Black women are also more likely to die from breast cancer. It's believed that that's because they're more likely to have what's known as triple negative breast cancer, meaning it has it's hormone receptor negative and HER2 negative. And we'll talk about that a little bit later. For Hispanic women, breast cancer is the leading cause of cancer death. That may be related to delayed screenings and late diagnosis. The good news, American Indian and Alaskan Native women have the lowest rates for developing breast cancer. Asian Pacific and Islander women have the lowest death rate. Are there different types of breast cancer? And the answer is yes. We can just look at the anatomy or the structure of the breast, and it'll be much easier to understand these different types. The picture to your right, or the diagram to your right, shows a picture of the breast. You can see these, I don't know if you can see my pointer, but some of the oval shaped structures, those are called lobules, and those are the place where milk is made. Some people might call them mammary gland, milk gland. And connected to those are these tiny little channels or tubes that are called ducts. And those carry the milk from the gland to the nipple. This is, of course, all in preparation for breastfeeding. The area around the nipple that's slightly darkened is the areola, but the breast is also made up of other tissue, fat, and you can see that if you look at um, the cut view. You see the fat that's distributed throughout, and then there's what we call stroma, just sort of lacy-like fibers that help hold things in place. So given those, you can very easily understand the types of breast cancer, given those structures. If the cancer starts in the lobules, the breast cancer is labeled lobular. If it starts in the duct, the little channels that carry the milk, it's called ductal. If it starts where the ducts end at the nipple, it's called Paget's disease, and it's very rare. Cancer that starts in the fat and stroma is called phyllodes, and in the lymph and vessels is called angiosarcoma. I put this slide in just because I wanted to emphasize the importance of becoming familiar with your own breast. Women are their own best advocates. A significant number of cancers are brought to the attention of a physician by the patient. That was true for me. And so it's important to know what your norm is. You know, old ladies like me probably weren't in the habit of standing in the mirror and looking at themselves, but it's important. Some of those, the things that you might notice that are different if there's evidence or symptom or sign of breast cancer. And all of these symptoms and signs, let me say, don't mean you have cancer. It just means you need to be evaluated, because most lumps and bumps that are found in the breast are benign. So basically, if we start the top row, that diagram there is of a nipple that's sort of inverted, pulling in. The next is having some discharge from the nipple. The one to the right is noticing, perhaps if you put your hand up into your armpit or axilla, probably would be easier to notice, and that's a bump there in the axilla. Probably represents either the tail of the breast or a lymph node. And so the rest of the pictures are very similar. The center, of course, is the norm. The left, I guess it's my left middle, the left breast there has a bump or lump. The one on the right just shows some swelling of that left breast. If you can, it's subtle, but hopefully you can see that. And then on that bottom row is just the one to your left. There's a dimple, meaning that the tissue sort of pulled in. And then, of course, you could have soreness, tenderness, or changes in the skin. And that's what those others represent. But anything that's different that you notice, don't be alarmed. Just have it evaluated by your clinician or physician. The most important tool that's been used for screening is mammography, mammogram. And so this slide is really about when do we start screening, primarily with mammogram. Screening guidelines, these are from the American Cancer Society. Just a note, I put here, screening can't prevent cancer, but it results in early detection when treatment is most likely to be successful. And we saw that earlier when we saw those that survived at 5 years or those that didn't have, the cancer was still contained in the breast. So the earlier the detection, the better the treatment, the more successful, I should say, is the treatment. Women with average risk, meaning they have no personal or family history of breast cancer, um, they have no gene mutations that would increase their risk. The recommendation is for the women between 40 and 44 to discuss with their physicians. They have the option to start screening every year. It's not mandatory, but it's an option that should be discussed in light of other historical elements. Women that are 45 to 54, the recommendation is to screen every year. And women older than 55 can switch. They can go to an every other year cycle or continue yearly. Women should continue as long as they're healthy, and the expectation is that they will live at least 10 more years. Um, those women, the American Cancer Society identifies high-risk women as those women who have gene mutations or have a first-degree relative, meaning your mom, your sister, or your daughter, a first-degree relative who has a gene mutation. There are some hereditary syndromes associated with breast cancer if that's part of your history, or you had a history of radiation when you were much younger, between the ages of 10 and 30. Those high-risk women, they recommend screening with mammography and MRI starting at age 30. Next slide, please. The other entity that makes recommendations with respect to screening is the U.S. Preventive Task Force. And actually, their current guidelines are being revised, and I found a draft document. And the draft document, which should be out soon, they're recommending all women starting at age 40 and continuing every other year be screened. They didn't make any recommendations for or against the use of ultrasound or MRI as another tool to mammogram to aid detection. So hopefully their final recommendations maybe will be out soon. What tools we use, what tests we do to get the screening done. And I mentioned mammogram many times. Mammogram is just low dose x-ray of the breast. And they take the breast and kind of flatten it between two plates to get a better view. Many women find that very uncomfortable. I found it uncomfortable with a breast implant because my fear was that something was going to rupture. It didn't. I'm sure they weren't using as much pressure as I imagined. So it only lasts a little bit. So even if it's uncomfortable, it doesn't last long. It facilitates early treatment and has significantly contributed to reduce mortality. There's some new things in mammography. What I'm talking about here with the kind of a tube view, just see a picture on a piece of film, is called a 2D mammogram. There are now actually 3D mammograms as well. And basically the pictures are taken at different angles and then computers used to kind of reconstruct a three-dimensional picture of the breast. The hope is that they have improved detection, better results. We don't yet know. The clinical breast exam used to be really big. This is the exam when you go in and have your provider, examine your breast. But over time, there's been little evidence that this helps find cancers early. And like I said earlier, cancers are growing for years before we probably feel them um, on examination. And that's a woman who's doing her own exam or the physician. So the woman is still, she's the key. She should be familiar with the normal appearance of her breast. She should feel and report any changes. So the clinical breast exam by the physician is not found to be extremely helpful in early detection. Ultrasound is used quite often when there's a suspicious area. Mammogram, find something, use ultrasound to evaluate. It's really good at determining whether a mass is solid or cystic. Cystic is generally benign, but fluid filled. It's really good at detecting that. And it can also be used to guide like biopsy needles. Um, so MRI is not recommended at this point in time as a screening exam alone. Um, it can be used if there's some inconclusive um, findings on mammography. Um, and it's also useful, we believe, in women who have very dense breast tissue. It's good at assessing the size and location of tumors within the breast. I wanted to just mention, I found this little assessment tool. It's a breast risk assessment tool. It's an online module, and you just go in and click and answer the questions. And I tried to use it, but because I have a history of breast cancer, it immediately kicked me out, said it wouldn't be accurate for me. But what it gives you once you click through, it's basically it uses your medical history that you provide in answer to the questions, your reproductive history, um, and it gives you a 5-year risk of developing invasive breast cancer and a lifetime risk. And those risks are compared to average women the same age and the same race or ethnicity. So if you're interested, just go out and take a look and kind of click through. It took about 5 minutes, not even 5 minutes. Um, so I think useful, and it's information that you can take to your provider um, if it states that you're at a higher risk than average. This is a really busy slide, and I wanted to just spend some time here talking about breast density. And there's a great deal of interest in breast density, but dense breast tissue is not a disease. It is found on mammogram, and it's just when the breast contains higher amounts of glandular and fibrous tissue, and connective tissue, and lower amounts of fatty breast tissue. It's actually common, about 50% of women above the age of 40. Sometimes dense breast is inherited, but it can be influenced by other factors, as, as is stated there, younger women, premenopausal, menopausal with hormone therapy, pregnant or breastfeeding, even lower BMI, meaning some thin women who have less breast tissue. Um, the reason I added this slide is breast density is important because women with dense breasts have higher risk of getting breast cancer than women with fatty breasts. And the reason for that is not known at this time. The other thing that's important about dense breasts is the breast tissue. If you look to the right, they're very, very extremely dense. You can see sort of the white. And that's part of the problem. Dense breast tissue appears white, as does calcifications and tumors. Um, so it makes it very difficult to, with a woman with dense breast tissue sometimes to differentiate or to see cancers or calcifications that occur with cancer. So um, it's important. The U.S. Food and Drug Administration recently published some updates to their regulations, and they're now asking mammography facilities to notify patients. This is as of May of 2023, to notify patients about the density of their breast. Um, so that's really important information to take home. I just added these pictures and this sort of classification system just in case you have a mammogram and you're looking at the reports and what is this? Um, these pictures here are basically how the radiologist will classify it. This one on the left, fatty, meaning significantly more fatty tissue. About 10% of women will fall into that category. Scattered means you have the fibroglandular material kind of scattered throughout the breast. But it's mostly fat. About 40% of women will have the scattered pattern. Um, Heterogeneous density, as you can see, just much more glandular, fibroglandular material. Um, about 40% of women will fall into this category, and then just the extremely dense, that's about 10% of women. So if you get those notes, don't be frightened by it. They didn't send it to you because there is a problem. They send it because they want you to be informed. And you can take that information to your provider and ask whether or not you need to have any other type of imaging in addition to your mammogram based on your history. So you and your provider have another tool to use in making some decisions. Next slide. So how do they make the diagnosis? The diagnosis is made by removing some of the cells and looking at them under the microscope. Um, and there's different methods you can do it. Fine needle is just like it sounds, just a little skinny needle, very thin, it's hollow. You put it in, through the skin into the lesion. You can withdraw tissue or fluid. If you're trying to get more tissue, you can use a larger bore needle, the core needle biopsy. Many people who have a large enough lump will have an excisional biopsy. um, an excisional biopsy just means they go in and they cut out the entire lump, and they usually will leave sort of a border or edge so that the pathologist can look at not just the lump itself, but the tissue around it, examine it for extension of the tumor, invasion, spread. Um, this is actually very common. I felt like I was going to surgery over and over. First the excisional biopsy, then of course back in for the mastectomy. This one's kind of busy as well. Once the pathologist has looked at it, looked at the tissue under the microscope, and they do special stains to look for receptors of different type, they'll produce a report. And you're like, oh, I had a cousin recently said, what does all this mean? Um, if they say something along the lines of hyperplasia, there's a picture here. It's if you looked at the cut pictures of cut ducts. The second from the first one to the left is normal. The second one from the left is hyperplasia, and you can see the cells kind of grow in an abnormal pattern, but they're precancer, and they increase the risk and will probably require um, some more vigilant and more frequent follow up. And it can happen in the duct or in the lobule, as we said earlier. These others are discussed on the next slide, but we can just talk now because I love these pictures. Carcinoma in situ. The cancer cells are still contained here within the wall of the canal. This is ductal carcinoma in situ. We talked about that earlier when we talked about the cases that are anticipated across this year, about, I guess, 50 or so thousand of these. Malignant tumors, here you see where the cells have invaded the wall. And here, the last one, metastatic, where it's invaded the wall into the blood vessel or the lymph system and spread to other organs. Okay. The other thing that the pathologist does is staining to look for receptors on the tissue or in the tissue. The receptor is a protein that's in or on the cells that can attach to things or substances in the blood. For breast cancer cells, they can have, you see I have ER, which is estrogen, PR, which is progesterone. They can have one or both of these receptors or none. You can be ER positive, estrogen positive, PR positive. If both of them are there or either of them are there, they may refer to you as hormone receptor positive. If neither of them are on the cells, hormone receptor negative would be your status. Hormone receptor positive cancers tend to grow more slowly. And there's therapy that can target the receptors, block the hormone receptors, and are really very effective. Hormone receptor negative tumors tend to grow more rapidly. They're more common in women who've not yet gone through menopause. The other protein that you might hear about is HER2. It's a human epidermal growth factor receptor 2. And the protein helps breast cancer cells grow quickly and more aggressively. There are treatments that target HER2 and they're very effective. We talked earlier about Black women who have triple negative breast cancer. And this is basically what we're saying. They have none of the hormone receptors and they don't have the HER2 receptor. And so there's no targeted therapy that can be very helpful. And the tumors are quite aggressive. I really wanted to talk to you guys about minimizing the odds. There are so many things with breast cancer that we can do absolutely nothing about. And that's pretty much what's on this slide. So we'll talk about those first. Gender, of course, we have no control. Women are about 100 times more likely to develop breast cancer than men. Growing older, of course, the older you grow, the more likely your chances or risk increase with age, I should say. We talked earlier about race with Caucasian women being slightly more likely to develop breast cancer, except in the very young ages where African American women are more likely. Family history. A family history of breast cancer, especially in a first degree relative, meaning your mom, your sister, or your daughter, almost doubles a woman's risk of breast cancer. If you have two first degree relatives, you might be as high as 3 times the average. Also, if you have a relative that was diagnosed under the age of 50, it increases your risk. And certainly a personal history of cancer increases the risk of a new cancer in the opposite breast or in another part of the same breast. Early menstruation and late menopause, that should say late menopause, I'm sorry. Basically, what that does is opens the time frame for exposure to estrogen the breast exposure to estrogen, which increases the risk. Giving birth at a later age, which is one of my risk factors. If you have your give birth with your first child between the ages of 35 and 40, and you have a 40% higher risk of breast cancer in the 6.5 years that follow that. After that time frame, it sort of slowly decreases back to normal or average. And then dense breast tissue, we just talked about the increased risk for breast cancer and inherited mutations. We haven't yet talked about. And BRCA1 and BRCA2, BRCA1 and 2 are the most common mutations in women with breast cancer. And this is just a little note on those gene mutations. Genes are sections of your DNA that operate inside the cells. They give instructions to make certain proteins, and those proteins have a job. And most of the gene mutations that are associated with breast cancer, their job was to manage growth of the cells or repair of cells. These are just the PALB2, TP53, PTEN, and CHEK2 are just some other mutations that are associated with breast cancer, but not as much so as they don't occur as commonly as BRCA1 and 2. About 3% of breast cancers, about 7,500 per year, are the result of BRCA1 or 2 inherited mutations. But it's important to know that not everyone who inherits the BRCA1 or 2 mutation will get breast cancer or ovarian cancer. Women who have it are have a 7 in 10 chance of getting breast cancer by the age of 80. But still, not everyone will get breast cancer because they carry that mutation. Women who have breast cancer that was diagnosed before the age of 50, I admit I have not done it because the copay was really high. And that shouldn't be a deterrent, but it can be at times. But diagnosed before the age of 50, it's very important, if not just for you, for your offspring. My daughter, I really need to have it done. Male breast cancer at any age. If you have multiple relatives on the same side of the family with breast cancer or some of these others, melanoma, pancreatic cancer, ovarian or prostate, especially if they're first degree relatives, should be tested. If there's a history of multiple breast cancers, or both breast or breast and ovarian, multiple breast and ovarian in the same woman. Ashkenazi Jewish heritage too. So we talked about things that we can do nothing about. Just be aware of the risk. But these are things that we can do something about. As far as alcohol intake, there's a clear link to increased risk. And it increases with the amount that's consumed. So, I'm not saying no alcohol, but certainly make sure that you consume in small amounts. Being overweight. After menopause, most of our estrogen comes from fat tissue, and that raises estrogen levels and increases the exposure of the breast and increases the risk. So weight management is very, very important, especially post-menopause. Lack of physical activity is a huge risk. Regular physical activity reduces the risk. We're not really sure how much exercise makes a difference, but we think that even a couple of hours a week might be helpful. More is probably better. oral contraceptives, there's perhaps a slightly higher risk of breast cancer. Um, but that risk appears to go back to average within 10 years of stopping use. There's not enough information to comment on IUDs or the use of Depo-Provera. Um, as far as diet, high-fat diets um, are believed to be risky. Um, there's no consistent link found. So diets high, but diets high in fruit and vegetables, and we're encouraged to eat calcium-rich dairy products. Low amounts of red and processed meats might also be important in lowering our risk. So we think diet's important, but we really haven't found a link to high-fat diets or other poor food intake. It's just important, for your overall health. Tobacco is a no-no. Heavy smoking over a long time. There's evidence that suggests that it's a risk, but it's not sufficient to say, oh yes. But we know that tobacco is a risk for heart disease and stroke because it causes narrowing of our blood vessels and damage to cells that line those blood vessels. We know it causes lung disease, emphysema, bronchitis, lung cancer. So, just cessation, just stopping it makes sense. We're not sure if vitamins make a difference. There's no strong evidence that it reduces the risk of breast cancer. One of the things that really piqued my interest was night shift work. I know a lot of us who have worked in hospitals and may do night shifts. It tends to increase risk. It seems to be influenced by the frequency of the rotations, and it may be related to melatonin levels, suppression of melatonin, or maybe just the interruption of your circadian clock. Um, it's inconclusive, but I found it interesting, especially for those of us who have been in a hospital setting and may have had to work some nights. Um, next slide, please. Mhm. So I just wanted to close by saying, yeah, everything changed when I got my diagnosis. So I just wanted to close by saying, yeah, everything changed when I got my diagnosis. I'm not the same. Um, I do carry scars that are reminders of the challenges I've faced, but also of the opportunities that have been extended to me. I am so grateful for the opportunity to be here today and to share my story, to encourage and to help educate you guys. There's a lot of stuff we can't control, but we're charging you today to identify your risk and change the things you can control and to kind of get started. It's interesting when I started preparing for this and looking at postmenopausal weight. And I started walking every day so, because I realized how important it is to shed some of this extra as it poses a risk for increased exposure to estrogen for me. So, in summary, just identify your risk, control what you can, know your breast, act quickly if you notice any changes, and keep current on your screening. Um, this is your life. It's your fight. Thank you guys for listening.
Thank you so much, Dr. Carter. We do have the chat open, guys, if you have any questions. I have one personally, Dr. Carter. How frequent is it for women who have no family history to get access to genetic screening? And then I guess this may kind of piggyback on what you said earlier about like increased copay or additional costs to get access to screening. So maybe that's a two-part. The first is like let's say I just wanted to be screened. I don't have any known family history, but sometimes people don't keep an accurate record of what great grandma or someone, even who was estranged from the family, passed away from. How would I
Mhm,
go about kind of advocating for that, or
mhm.
you know, what
I would
would be the
say,
best
I'm
case
sorry,
scenario?
I would say when you present for your well woman exam, especially if you have people in your family who died at an early age or who died from unknown causes, make that known and include that in your history. And the providers can certainly present that to the insurer. Um, Generally, the insurance companies, here I am doing that kind of work. We want to see that people meet the criteria, meaning they're at risk. Um, so if you have some questionable history in terms of, I don't know what they died of, or I would include all of that. Um, and if there are any other things that raise concern, you're just concerned in general. You just want to know. Is that what you're saying? You just want to know.
Well, I think a lot of time people hear about the frequency
Mm-hmm.
of breast cancer diagnoses, and so they're like, well, I need to make sure that if I am someone who has it, that I catch it early. And so you want access to every single screening, and you want as much information, you want to know
Mm-hmm.
everything that you
Mm-hmm.
can.
Mm-hmm. Yeah, it's expensive. I would say that many times the insurer, if they don't have reason to believe that you're at risk, they probably won't pay. Um, but if they think you are at risk, and I mean, I would share, everything that you can as far as your history. Um, then if you're at risk, meet criteria, they'll pay. If you're not at risk and don't meet criteria, they're unlikely to. And it's probably about $1,200 the last time I looked. It may not be as expensive these days. Um,
Thank you.
mhm.
Thank you again so much, Dr. Carter. This was extremely informative. We've had other breast cancer awareness webinars and events in prior years, and I learned so much more information from this one. I like the fact that I kind of get to build on to the knowledge that I
Mhm.
had in the past, but getting a little bit deeper.
I'm glad. I thought I was going to be too emotional.
Thank you for sharing your story as well.